You are welcome to today's update. I'm going to do a little bit about the increasing cases in children in the United States, and we'll also be looking at trends in the UK and the US. And then I've got a bit more thinking on why the death rates seem to be so low at the moment compared to increasing numbers of cases. And as time permits, we'll also look at an effective non-pharmaceutical intervention that I've been thinking about. Now, I want to start with Mexico, where we've looked several times. So we've seen that the cases in Mexico and the deaths they don't look as bad as other countries, but of course these are minimal estimates. The real numbers are going to be higher than this. So Mexico has actually been quite badly hit by the pandemic. And what caught me was that the stage 3 clinical trials are going to begin in October for Sputnik V, which of course is the Russian vaccine. Now, I must apologise. I was brought up in the era of the Soviet Union. I used to listen to Radio Moscow under the bedclothes at night sometimes. It was either that or Radio Luxembourg. So I'm kind of used to the Soviet Union, but of course it became Russia many years ago. I mean Russia, of course. But the Russian stage 3 trials for Sputnik V, their vaccine, start in October in Mexico. And they plan on recruiting several thousand volunteers who will test that vaccine in our country as close as next month. This was one of the, it is in italics, so this is one of the senior politicians in Mexico speaking. Now, Mexico has been looking round for vaccines, and it seems that the Russian vaccine is available. Very, very convenient. Now, I'm not comparing this to October 1962. I mean, Cuba's a bit further away than Mexico. You see, you can split from the United States into Mexico. And that means that there's going to be Russian doctors, nurses and healthcare advisors in Mexico. I'm sure there won't be anyone else apart from nurses, doctors and healthcare advisors. And that's very close to the United States. So this could potentially be an uncomfortable situation. And this does bring us on to this idea of the contest for influence and prestige that comes with vaccination. So it looks like the Russian vaccine is getting a foothold in Mexico. Now, if I were in the United States, I probably wouldn't consider that to be ideal. So one alternative might be to offer Mexico vaccination from the United States before someone else does. So this is just some of the problems that I'm afraid I do see coming as people around the world, I'm not saying it's true in this case, but people around the world could well use vaccine as a means of soft power, perhaps with a capital P. So even if it's only enlightened self-interest, we need to make sure this vaccine is available to everyone in the world who needs it, from reputable suppliers and manufacturers. Now, moving on to the United States itself, increase in child cases. Now, let me just go to this graphic a minute here. So this graphic here is the proportion of the cumulative COVID-19 cases that were children. So here, back in April, 2% of people that were tested were children. Now it's 9.5% of people that are tested that are children, testing positive. So the proportion is increasing. This is what we're noticing. This is a definite trend here. So definite trend of increasing proportion of cases in children in the United States. Now, surprisingly, only 43 states report age data. Now, I must say I've been taken aback by the lack of data gathering in the states. We've already looked at the lack of data gathering as regards to ethnicity. And now we see that 7 states don't even bother reporting how old people are. I mean, this really is quite, well, I'm incredulous about this. So only 43 states reporting age data, but that's the current status at the moment. So there you go. Someone needs to sort that out. Now, child cases moved up to 9.5%, as we said, of the cumulative cases. Week ending the 27th of August, which is the last week for which there is full data, we have 44,000 new pediatric cases in the week. And of course, that's the US spelling of pediatric, seeing it's US data. An extra 44,000 children testing positive in the week. So quite high numbers. Now, the reason I've sort of dwelling on this a little bit was we did look at this situation in Madrid yesterday. Was it yesterday? I think it was yesterday. And this president of Madrid in Spain basically was saying that she expects all the school kids, practically all the school kids, to catch it. So in Madrid, the president of Madrid is expecting everyone to catch it. And cases are increasing in the United States. And quite what this means, we'll look at a little more what this means shortly. But first of all, let's look at the cumulative number of infected children. So cumulative number of infected children, now up to nearly 500,000 children have been infected from the over 6 million people infected in the United States. And these are the percentages of children infected compared to the total number of positive cases in different states. Now, this could just reflect testing bias. We haven't reported on all states, obviously. They're just some of the lower ones and some of the higher ones. I know New York City is not a state. So that could reflect testing bias. Or is there something else going on here? It's something we're certainly going to need to think about for the proportion of children affected. Now, the implications for children, what does this mean? Well, so far, children's hospitalizations in the United States have been 1.7 cumulative number for all ages. So, in other words, 1.7% of the admissions in the United States have been in children. Now, what this data doesn't tell us is how children are defined. I think this means up to the age of 17 in the American data. But child hospitalizations in Hawaii are relatively low, child hospitalizations in Arizona are relatively high. So again, this needs more unpicking just to see what's going on here. Now, what does this mean for child mortality? Now, we know child mortality is very low, but some children do get sick and a few children tragically have died. So what are the actual figures on that? What can we expect? What have we had? Nationwide, 0.07% of all COVID-19 deaths have been in children. This is in the USA. That's the US data. 19 of the 43 states reporting distributions have had no deaths. So only 43 states that report age distribution data, but 19 of those states. So in 19 states, we know there's been no child deaths, which is, of course, good. But there has been 101 child deaths as of the 27th of August. So it's not like there's no risk. And if the president of Madrid in Spain is anything to go by, it looks like a lot more children are going to get infected as schools go back. And I have been anticipating this for some weeks. That's going to spread to families, grandparents, all sorts of things. It could mean that there's going to be a significant increase in cases with the reopening of schools, if that Spanish thinking is anything to go by. Now, trends in the United States generally. New York cases are down with progressive reopening of things. Fairly well controlled from what I can gather in New York, fairly well controlled. Local authorities and people in New York seem to have been doing a fairly good job of this progressive reopening. There is debate about it. Now, I'm just going to say one thing briefly. A few of the Democrats in the United States have realised I'm a closet Republican. And of course, a lot of the Republicans in the United States have realised I'm a closet Democrat. I've been accused of being a fascist and a socialist. I have not picked on any political grouping to criticise or to praise. I don't really take notice of it. I know I've criticised governors and people like that, and basically I don't know whether they're Republican or Democrat. It's just not an issue. So, but there you go. So I'm a closet socialist and I'm a closet fascist. Believe which one you want, or neither, of course. Anyway, sorry, side issue. Midwest cases increasing in the Midwest area. These states, Iowa, North Dakota, South Dakota. All of these 3 states have more than 20% positive test results. So of the tests that are done in these 3 states, Iowa, North Dakota, South Dakota, of the tests that are done, 20% are positive. Now this is high, and this indicates ongoing community transmission, which means there will be more cases coming up soon, officially recognised cases. So that is increasing in the Midwest. There I am. Right. Iowa, for example, plus an additional 8,300 cases last week, up 116% on the week before. So increasing cases pretty well all over the Midwest. Minnesota, 27% increase last week. Indiana, 35% last week. So an area to keep an eye on, and certainly one where, if you live in that area, all the usual rules are particularly important just now. Now, the UK has had some increase in cases. So we noticed from the official data just yesterday, I think it was, from the Office for National Statistics, that the number of cases was fairly stagnant. But just in the last week, there has been increases in cases. So cases weekly were up 6,732 cases, and that's the highest weekly increase since May, up 6% on the week before. So that is England NHS Test and Trace. So that's data reporting on the 26th of August, so even that's out of date now. There's always this lag in the data, of course, the proper data, so that's an increase, and it could well be have increased again by now, early September. Contacts reached down to 69.4%, down from 77.1%. So of all the people that are reported as potential contacts, we're only reaching 70% of them at the moment. This is not impressive that we're only contacting 70% of contacts and advising them to self-isolate. In other words, 30% don't know they've been exposed to the virus, of people that we know are positive. So it's not too impressive. Now, the ongoing saga of high cases, low deaths. Now, we have looked at this. The cases are very high in places in Europe, for example, but the death rate is low. Now, of course, we've looked at several reasons for this. The main one's probably the demographics. Younger people are getting the infection. And we've also looked at the lower antigen dose, the lower dose of inoculum as a result of using masks. But a local analyst, Dr. Andrew Bailiff, has contacted me, and he pointed out something which is actually basically completely obvious once you realise it. Let's have a look at what he said. What we can call the first wave, I don't like the term, but for argument's sake, March, April time. Most testing was based in hospital. Patients presented with relatively severe symptoms. So remember, back at that time, there was a great shortage of testing, and testing was done on clinical grounds. So the people that were being tested, by definition, were the sicker people who were hospitalised. And of course, a much greater proportion of those could potentially go on to die. So it wasn't the same sample that we're taking now. It was a sicker sample. Now, in research terms, this is what you call a self-selecting sample. They didn't really select themselves, but they kind of did, because they were the ones that were sick. So biased towards older patients with comorbidities, who are more likely to go on to die anyway. Most positive cases were never tested, therefore undiagnosed, because testing was simply not available. Therefore, many of the asymptomatic and mild cases in the early stage were simply not diagnosed. So that means that we were taking the number of people that we thought were infected and the number of people dying, and because we were only sampling the people that were already sick in hospital, obviously the percentage of death rate would be much higher, the case fatality rate would be much higher. And it was about 10% at one stage, I think, certainly 6-7%. And we knew it was inaccurate at the time, but we didn't know how inaccurate it was. Now, comparing that to what we might call the current wave, there's hugely more testing now, many via track and trace. And the thing about testing via track and trace is we're picking up a representative sample of the total infected population. which of course is young people, people without comorbidities, people that have got a much lower probability of going on to die. So mortality rates for recent cases will be biased towards the statistical true outcome. In other words, the sample of positive cases that we're getting now represent the whole population of the country, because we're doing much more testing in the community, whereas before a lot of the testing was in hospital. It wasn't a representative sample. So the numbers we're getting now are much more representative of the whole population, therefore much more likely to be accurate. So the death rates are panning out in the UK at least to be much lower than we'd feared. This is actually remarkably good news. We're getting much nearer to the true infection fatality rate. Testing's more than 100 from the early weeks, so we're really comparing apples and oranges. You can't compare apples and oranges. Apples would be the number of cases in the first wave in March, April, just testing in hospital. Oranges would be the number of cases now. And this is reflected in the data we looked at, I think it was a couple of days ago. The Office for National Statistics was saying that the infection fatality rate was 0.49 up to the 4th of August. And of course it will be even lower now as we have more test and trace people being officially diagnosed and added to the number of infected people. We noticed that the Medical Research Council, it was 0.3%. So really quite very good news. So that's probably the main reason why we're seeing the lower levels of death compared to the number of infections. And we won't look at it again now, but we've looked at the graph of Spain and France, for example, where the number of infections is really quite high, but the number of deaths remain quite low. So the number of people dying now compared to the number of people being tested positive now is remarkably low, because we're testing many people in the community who may even be asymptomatic. They're being tested through the trace and the test and trace system. Therefore, they're contacts of people that have been infected that might not even know they're infected. So that's looking like the actual infection fatality rate will probably go on falling, at least in the UK. That could well be the situation. No guarantees, of course, but that all makes sense. So thanks to Andrew for that. Perfectly obvious when you see it and explain it in those terms. But sometimes the most obvious things aren't got. And this really makes you wonder about some of the early prognostications. Remember the Imperial College numbers that we were looking at the start of this epidemic, the Neil Ferguson group number, for example, where the infection fatality rate appeared to be frighteningly high. Could it be that such senior academics failed to realise they were testing a non-representative sample, that they were testing a self-selecting sample of people that were already sick, and they were missing the vast majority of people that were infected in the community who were asymptomatic? Could that be because that's determined the whole policy that the Western world has taken, really, and certainly the policy the UK has taken? And I think there's certainly question marks over that now. So anyway, for today, the infection rate is looking way, way lower. Now, the deaths will rise slightly because there's always a lag effect, but the infection fatality rate is way lower than we'd thought. Could even turn out to be lower than the 0.3 currently suggested by the Medical Research Council. And I wouldn't be surprised if new data that we get in a few weeks' time related to the situation now gives us an infection fatality rate of 0.2 or lower. So it's actually really good news. The infection fatality rate is going down, has gone down dramatically. Now, moving on to non-pharmaceutical interventions. I like that. Don't like taking drugs if I can avoid it. And this is a contact tracing app. Now, this is new modelling data. Contact tracing app can sharply reduce the spread of COVID-19, even only when a few people are using them. These apps can be remarkably effective. So this is now not peer-reviewed yet, but I've read the paper and it looks pretty good data to me. Collaboration between Google and the University of Oxford. Now, I know immediately I've got all the civil liberties lot saying I'm a neo-fascist, but I'm reporting what's here, and personally, I'm perfectly happy using apps. I'm not a neo-fascist, by the way. An app used by 15% of the population, together with a well-staffed contact tracing workforce, can lead to a 15% drop in infections. That is quite an impressive reduction in infections. Very impressive reduction. So presumably 30% of people using the app, a 30% reduction in infections. I mean, this is quite staggering. And that can lead to an 11% drop in deaths. So even if only 15% are using this app, provided all the pings they get on the app are followed up, and as we noticed at the moment, we're only getting about 70%, that would depend on that, on good follow-up. We would need more than 70% that we're getting now in the UK test and trace. More than that, but if that was, presumably if that was 100%, that would be a 15% drop, 11% drop in deaths. Now, this is another complete debacle in the UK and many countries. We tried this app of our own in the Isle of Wight. It didn't work because we tried to develop our own technology kind of from scratch. Now, I don't know what it's like in your country, but in my country, healthcare is replete with technological disasters. We had an all singing, all dancing computer system for the health service, and it never worked, and I think it lost about £13 billion. That's right, £13 billion, as far as I know. Correct me if I'm wrong on that, but it was just a complete debacle because it didn't use existing technology. It was trying to do it all on its own and be clever and have an all singing, all dancing system. They just don't work. So this uses Apple and Google collaborating with very well established technology. Technology we know works with pinging Bluetooth signals. It's anonymous. It notifies a person if they've come into contact with someone COVID-19. So in other words, if someone tests positive for COVID-19, all the Bluetooth pings, the connections on their phone for the past few days will be, all these phone numbers will be flagged up. They can be texted and contacted and say, oh, you've been in contact with someone who's tested positive. Go and get yourself tested and isolate for 14 days. And that saves all the country locking down if you do that. Now, in the past few weeks, this has been rolled out in 6 US states. It's been rolled out in a couple of dozen countries, and there's been no major hitches because it's using recognised technology. And Google and Apple, as far as I know, have agreed to delete the data after a particular amount of time, but you're not geolocated anywhere. It is just a Bluetooth ping. Your phone knows if it's been within 6 feet or 2 meters of another phone, presumably for a particular period of time, and that can massively reduce transmissions and deaths. So yeah, where can I download it? You know, I'm just waiting for it to come. It's I can't download one yet. I mean, the data that we've got from the COVID symptom tracker app that you just report in every day, the Tim Spector group, is just incredible. 4 million people doing that now, and you go onto the website there, and there's just masses of incredibly useful data coming out. Not just about COVID-19 as well. They're doing research about diet and health and all sorts of stuff. You know, with a sample size of 4 million, you can get really good data. So I think it's a great idea. Oh, Thailand. I reported yesterday Thailand had no cases in 100 days, and as soon as I clicked the stop button on the video, they had a case. So anyway, it was a prison inmate was diagnosed. Dozens of contacts now are being tested. He was arrested for drug offences on the 26th of August. Now, where he got it from, I don't know. If he was arrested for drug offences, he could well have come into the country illegally or via some dodgy means. So perhaps nothing to be too concerned about, and I'm sure the Thai authorities will do the usual job of quarantining and isolating. Right, lots of people don't want an RNA vaccine because the RNA will get into the DNA and change the DNA forever and change the DNA of the human species and will become something else. No, it won't happen. Let me explain why. Now, with the if we take, for example, the RNA from the HI virus, human immunodeficiency virus, so that's the single strand of RNA from a human immunodeficiency virus. That gets into the cell, and imagine that's the nucleus of the cell there with the DNA in there. Now what happens is, because the HI virus is a particularly devious virus, it puts in an enzyme called reverse transcriptase. Now what normally happens is DNA makes RNA, makes protein. That's what normally happens, and the process from DNA to RNA is called transcription. So that process is called transcription, and the process of RNA to protein is called translation. So it's transcription and translation. But the HI virus has this thing called reverse transcriptase, so it can do it the other way, so it can convert that RNA into DNA, and the DNA actually gets into the cells and it will stay in your cells. That's why HIV is not curable, it's only manageable so far. But the RNA vaccines don't have any reverse transcriptase, so it's absolutely impossible for the RNA from the vaccine to get into the DNA. Don't worry about it, it's conspiracy theory, it's bunk, forget it. It's not saying there'll be no problems from RNA vaccines, they're being tested now, but the RNA from the RNA vaccines will not get into your DNA. It breaks the laws of biology as I understand them. Okay, so I think that's long enough for today. Thank you for watching as always. Interesting things over the next few weeks. Let's hope these apps really get going and that brings the cases down. Let's hope the infection fatality rate continues dropping below 0.4 or 0.3 down to 0.2 or even, dare I say it, 0.1. Certainly, hopefully it will drop below, down to the 0.3 level or even below that. And the big unknown at the moment is what's going to happen with infections as children go back to school. I suspect what we got from the president of Madrid was a moment of candour, and that many children could become infected, but thankfully not many will get sick and very few will die. But what that does to the infection as autumn approaches is what we don't know. As we said, we hope the infection fatality rate continues to go down, but it could go up in winter as more older people and more people with comorbidities could get infected over winter. Because I know we've talked about these vaccine programs coming out in October for some workers, but the bottom line is that most of us aren't going to get vaccinated until 2021. So for the vast majority of us, we still have to get over this winter. Thank you for watching, as always.